Welcome to AETCM, the emergency medicine channel. Today let us discuss about hepatitis B virus. You all may be knowing that hepatitis B virus is spreading from a person to other person through blood-borne route. It can be by an injection drug abuse or a contaminated injection, which is we are getting needle prick as a healthcare professional, or sexual route, unprotected sexual contact. These are the common causes for hepatitis B virus infection, whereas hepatitis A and E, they spread through fecal-oral route. Here hepatitis B, hepatitis C, hepatitis D, all these things spread through blood-borne routes or blood products. Now this is a DNA virus, so you can see the hepadene virus. It's a hepadene group transmitted through percutaneous needle prick injuries, percutaneous injuries, or whatever it is. It spreads through the skin or contaminated needle prick, or any surgical material, whatever it is. It can spread through percutaneous route. Intravenous route, that is very important for healthcare professional when we are giving injections or trying to give some trying to do some procedures. When we get prick injuries, either by needle or surgical knife or whatever it is, so that can spread through that route. Another important problem is drug abusers. So drug abusing is one of the most important problem nowadays. Drug abuse means IV drug abuse. So when we share the needle, when we take a drug and we share the needle, actually the blood is there in that bore of the needle, so it can spread from one person to other person easily. Blood transfusion nowadays, it is very rare, because blood transfusion as such can produce hepatitis B or HIV or hepatitis C, but nowadays we take all precautions before blood transfusion. But even then, that's a route of contamination. Sexual contact, unprotected sexual contact, that word is very important. Unprotected sexual contact is very important. Mother to child during delivery, that also can produce spread of virus. Around 70% of the patients with acute hepatitis B infection have subclinical or anictric, that means without jaundice hepatitis, while 30% develop icteric phase. So if you follow up the case of hepatitis B, so many patients are having no symptoms, they are asymptomatic, but when we do some investigation, we can see that hepatitis B is positive, but they never give a past history of any jaundice. But 30% of the patients actually develop icteric phase of the hepatitis, and they come to the hospital, they do investigation, and we can know that. Fulminant hepatic failure, acute infection is, during acute infection it is not very common, but it occurs in patients around 0.1 to 0.5% of the total number of patients. But we don't know exact number of this fulminant phase, because many of these patients are undiagnosed. So we have already seen that subclinical is more than the clinical jaundice. So this may be higher or lower. We don't know what is the exact number, but whatever available data, it is 0.1 to 0.5% of the patients. It can go to the fulminant phase. So from this 30%, around 0.1 to 0.5% can develop fulminant hepatic failure. They can have liver failure, hepatic encephalopathy, all these things. And many patients, actually 1 to 10% of the patients, can go to a chronic carrier state. They do not have a disease, but they are harboring this virus. They can spread to another person. So they have the hepatitis virus, but no disease, no clinical features, but they can spread to another person. So personal contact, or whatever we learned in the last slide, can spread this virus from this person to another person. Some patients can have this virus, but they have very low replication phase in their body, so they may continuously have a viral load, but liver disease will not be there. So chronic hepatitis B means person is infected with hepatitis B virus, but they do not have any active disease at present. So that is sometimes called as carrier state, because they can spread the disease from the infected person to other person. So there are different phases for that. Chronic hepatitis, they can have mild elevation of SGOT, SGPT. Some may progress to cirrhosis. They can have AG reversal, they can have PTNR elevation, they can have ascites, all these things. Then some may develop hepatic failure. So from there they develop hepatic encephalopathy and other features of liver failure. Some develop hepatocellular carcinoma. That means they can develop tumors inside that cirrhotic liver. And many can have extra hepatic features. They can have other immunological disorders due to this virus, and some ultimately succumb to death. That is mostly due to hepatorenal syndrome and hepatic encephalopathy, bleeding tendency. Fulminant hepatitis can occur in some patients, even in chronic phase. That is also known. Hepatocellular carcinoma occurs, like patient can develop carcinoma. Extra hepatic manifestation like PAN, polyarteritis nodosa, that's a vascular disorder. Nephritis, that is glomerular nephritis. Cryoglobulinemia, that's a vascular disorder. Serum sickness like features, like patient can have arthritis, joint disorders, all these things. Skin rashes, some dermatitis, aplastic anemia. So these are the common extra hepatic manifestation can occur in hepatitis B virus. So vasculitis is one of the most important feature of this hepatitis B virus. Now, which all factors predict the severity of the disease or severity of or progression of the disease? One is patient who is having prolonged replication phase, HBe antigen positive for a long time, they have worse prognosis. HBV DNA levels, if the viral load is very high, that is a bad prognostic. This one. HBs AG level, that is the most common investigation we do in our practice. If the levels are very high, then that is a bad prognosis. Co-infection with HCV, HIV, all these things are also very bad prognosis. HTV co-infection, that is also bad prognosis, but nowadays routine practice, we don't have any investigation to make HDV positive or not. Now there are a lot of antigens that we'll see afterwards. In the next slide we may see that. A lot of antigens which can pick up during the acute phase, and some antibodies during the follow-up. In that, HBsAg is the most important investigation. HB core antigen, HBe antigen, HB core X protein, HBV DNA. So these are the most important investigation we do in our practice, but to make a immediate diagnosis, we always ask for HBsAg. Now, if you see this slide, you will understand which are most important investigation. In acute infection, HBsAg is positive. You can see here HBsAg is going up like this in acute infection. Okay. Then if HBsAg present in blood during the prodromal phase and lasts up to 3 to 4 weeks usually, if HBsAg remains detectable more than 6 months, you can see here normally it comes down, but if it is persisting for longer time, then you have to suspect chronic hepatitis B infection. So here you can see HBsAg. In acute it is positive. When it is positive for more than 6 months, you have to suspect chronic hepatitis B. Antibody to HBsAg. So if HBsAg is the antigen, there will be antibody production. So if you are taking vaccination, that will be persistent for a longer time. When you get a needle prick injury or something, you can ask for anti-HBs. If anti-HBs is dropped there, you have to again take your revaccination should be done for that person. Next one is HB core antigen. So HBC antigen, antibody to HBC. It's not detectable in blood test, but anti-HBC IgM is seen in acute infection and anti-HBC IgG is seen in after recovery. So the antigen is not detectable. HBC antigen, core antigen, you can see here. So the antigen will come like this, then antibody formation will be there. HBE antigen, that indicates the replication. Persistent HBE antigen indicates active replication. So that is a very important investigation. So you can see here. So it is positive here, it is positive here. But normally when it is cleared, it is not positive. If it is persisting, then that indicates chronic replication phase of the hepatitis B. HBV DNA it's a DNA virus. If you pick up this DNA, if it is very high, more than 10 to the power of 5, it's seen in active replication. Again, HBV DNA also indicates an active replication. Now HPV DNA, so it's wrong, 10 to the power of 5 is correct. So 10 to the power of 5 copies per ml seen in active replication. So that is very important. Acute hepatitis, it is very high, and again active replication also it is very high. High replication. In low replication it will be low. Okay, so that is very important. So we should remember about HBV DNA to know whether the virus is actively replicating or not. Suppose a person who is having HBsAg positive, and even LFT is also abnormal, like SGOT, SGPT is elevated, then you can check for the HBV DNA. If DNA levels are very high, then that indicates it's a chronic phase, but chronically actively replicating phase. So that is the importance of HBV DNA. Now these are the it gives an overall picture of what all tests you should do in acute phase or after chronic phase and how to interpret that. So you can see here HBsAg is positive in acute hepatitis B. If it is presenting more than 6 weeks, then you can think about chronic phase. So that is 6 months it is chronic phase. So that is very, very important. So we have already discussed all these things in previous slides, so I am not going to that slide again and again. Other lab investigations. See, once you know that hepatitis B is positive, we always should rule out whether the patient is having an active liver disease or not. So what all things which will tell you the active liver disease? One is SGOT, SGPT elevation. Normally in hepatitis B infection, during the acute phase, you can see SGOT, SGPT may go up to thousands and they come back to normal. And for a longer period, it may be normal only. And some patients that go to the chronic phase after 6 months, if hepatitis B is positive, HBsAg is positive, then if it is normal, then there is no active hepatitis. But if it is SGOT, SGPT is slightly higher, then there is active hepatitis. Then you see HBV DNA. If DNA is negative or it is very low, then that SGOT, SGPT elevation may be due to something else. It may not be due to the hepatitis itself. But if HBV DNA also high, then you should think that there is an active replication of virus, and this SGOT, SGPT elevation is due to active hepatitis. Then bilirubin elevation, again liver injury, direct hyperbilirubinemia can be there, and PTINR also can be elevated. If there is a chronic liver disease going to cirrhosis, then albumin level can be low. So PTINR and low albumin indicates functional liver capacity. Always check the hepatitis HIV virus, HIV ELISA, because 7% of the person who are infected with HIV, they can also have HBV. Both virus have similar clinical picture for spreading the disease from one person to other person, and the treatment with hepatitis, whatever treatment we are giving HIV, some drugs can also be given for hepatitis B. So it is very important to test the HIV virus, because many drugs used in hepatitis B virus actually can be used for HIV. But here you may be giving a single drug that is for hepatitis B virus, and the same drug is used for HIV, but that drug is in combination with other drugs. So here we give mostly 3 drug combination. One of the drug may be active for hepatitis B. If you are using only that drug here, and slowly this patient who is having HIV co-infection can develop resistance to that drug. So we have to be very careful. All patients who is having hepatitis B infection, HIV should be ruled out. And one more thing is you have to go for liver biopsy, that I didn't tell. Liver biopsy is very important because if the patient is developing chronic infection, chronic hepatitis, chronic cirrhotic features, then liver biopsy may be required to make a proper diagnosis of liver cirrhosis. But we have MRI or fibroscan, some other scans, we can avoid our liver biopsy schedule in many patients. Acute hepatitis treatment is only supportive, and N-acetylcysteine is one drug which is used basically in paracetamol poisoning. That drug nowadays we use for all types of acute liver failure, whether it is paracetamol poisoning, rat poisoning, or hepatitis B, acute viral hepatitis. All these conditions we are using N-acetylcysteine. The dose is actually from paracetamol poison itself, but some doctors give 600 milligram IV TID, but we routinely use the same dose of paracetamol poisoning in acute liver also, liver injury due to any cause. Most of the cases recover without any problem. Okay, some may persistently have hepatitis B, HBsAg positive, so that will be termed as chronic carriers. Some may have HBsAg positive with some liver injury, SGOT, SGPT will be elevated, liver injury can be there, so they have chronic hepatitis. Some may have actively replicating virus, HBV DNA will be, levels will be very high, so the replication phase is very high. So all these things are there. Now there are a lot of antivirals which can be used. Indication for antiviral: coagulopathy more than 1.5, persistent symptom, marked jaundice, bilirubin more than 10 for more than 4 weeks after presentation. In patients with fulminant hepatitis B, reduced likelihood of reinfection post liver transplant. In patients who are immunocompromised, patients who have concomitant infection of C or D virus, patients with persisting liver disease or elderly, all patients we can use antiviral during acute phase. So these are the commonly used drugs: entecavir, tenofovir, lamivudine, adafovir, telbivudine. All can be given as a monotherapy, but we should only remember one thing: this tenofovir and lamivudine is used for HIV also. So it is better to check the HIV ELISA and rule out HIV infection. If HIV infection is associated, you go for triple drug therapy, 3-drug therapy for HIV. In that, one of the drug will be tenofovir or lamivudine. If you give only one drug in co-infection with HIV and hepatitis B, that drug alone will become resistant for HIV. Treatment can be stopped after confirmation. 2 consecutive tests for 4 weeks apart can be done for HBsAg clearance. Now, chronic infection indication for treatment: elevated, persistent elevation of SGOT, SGPT. There will be some problem there because SGOT, SGPT can be elevated in many other conditions, including alcoholism or a patient who is having fatty liver. So it is then that type of patients may require a liver biopsy. Very higher viral load. We have already discussed that DNA more than 10.5. For HBsAg positive with evidence of chronic HBV disease, treatment is given when the HBV DNA levels more than 20,000 and when serum alkaline or aminotransferase ALT is elevated more than 3 to 6 months. For HBe negative, that means replication is negative. Chronic hepatitis B treatment can be given when HBV DNA more than 10 to the power of 4 copies and serum ALT levels more than 20 units per ml, female 30 units per ml for more than 6 months. Or histological evidence of active inflammation by liver biopsy. Suppose you are not having all these features, you are in doubt, then only you should go for liver biopsy. So chronic infection, again treatment will be lamivudine 100 milligram per day for 1 year, Edifaver 10 milligram per day for 48 weeks, tenofovir can be given 300 milligram OD for 48 weeks, Entecavir orally 0.5 milligram, telbivudine 600 milligram once daily, or alpha interferon therapy also can be given in patients who is having low viral load. So this is the chart which explain you which all drugs can be used for chronic hepatitis or chronic viral hepatitis, hepatitis B, with dose and duration is given here that I have explained in the previous slide, but it is given in a chart. And sometimes nowadays we use genotyping test. There are 8 genotypes, A to H. HBV genotypes D and C are associated with lower rate of favorable response to interferon alpha therapy than genotype A and B respectively. Some studies shown that the rate of resistance to lamivudine was higher in patients with HBV genotype A infection than patients with genotype D infection. So some points we should note that HBV DNA and genotyping is very important nowadays, because some newer drugs have come that will be very useful for some type of genotypes. So this chart tells you how to go ahead with the treatment with genotyping. Now prevention is very important. So if we are working in a field of healthcare area, then all healthcare professionals must take hepatitis B vaccination. That is very important. 3 doses, 0, 1, 6. That is very important. You have to remember that dosage. This one, and protection is 80 to 90% for 5 years and 60 to 80% for 10 years. So it is better to revaccinate after 10 years, or you check your booster dose after seeing the anti-HBs level. So anybody who is working in a hospital healthcare setup where we are dealing with hepatitis B patients, it is always better to check our always better to take the vaccination first, and after 5 years 10 years check your anti-HPS level. If it is falling less than 10 ml per international unit per ml, then international unit per ml, then you better take the revaccination schedule, or if you get a needle prick injury, then check that whether your anti-HPS levels are good or not. If it is dropped less than this, then better to take vaccination and immunoglobulin. For an unvaccinated person, or who is taken vaccination and their levels of HBS anti-HBS titer is less than 10 IU per ml, then better to go for immunoglobulin. So immunoglobulin dose is 0.06 ml per kg single IM injection, followed by hepatitis vaccination. Reschedule of vaccination should be done there. Now this chart will tell you what is the major difference between each type of virus. I am not going to read everything here because I have not covered other types of virus. I just concentrated on hepatitis B. It is hepadenovirus, DNA virus, stool it is negative, but all other body fluids it is positive. Chronic infection is 1 to 10%. Prognosis in acute it is good. Once it go to the chronic phase, it is not that good. Severity, very rarely it will become severe hepatitis because fulminant hepatitis is only seen 0.1 to 1%. Cancer, it is there. Some risk of cancer is there, especially in chronic hepatitis. Treatment we have already expressed, we already discussed. Interferon, lamivudine, Antivirals, Entecavir, telbivudine, all of the treatment choices. Vaccination, 3 doses, 0, 1, 6 months. Passive immunization, hyperimmune serum globulin 0.06 ml per kg. So we have discussed about one of the important healthcare hazard, that is hepatitis B infection. HIV, hepatitis B, hepatitis C, all can spread through needle prick injuries. So we have to be very careful. We should avoid needle prick injury. How to avoid needle prick injury? That is very important. We should never try to recap the needle. That is very important. Most of the time needle prick injuries are during recapping of the needle. So normally when we take a needle and give the injection, we try to recap it like that. Either you should never recap it, keep it there and put it in the dustbin or whatever bin you have. That the healthcare professional will have a color coded bins. In that, sharps should be kept in one type of bin. You should keep it there. Or when you are trying to recap, keep the cap on the bed. Never hold it like this. Keep the cap on the bed and try to recap like this. So that is also not advisable. Advisable thing is, don't try to recap, put it in the bin which is color coded. Only sharps should be kept in that area, because hepatitis virus can remain in the needle for a longer period, whereas HIV will remain in the needle for only few minutes. So that is the problem of hepatitis B virus. It can remain stable in the normal environment for a longer period than HIV virus. So we have to be very careful. We should not try to recap the needle. And drug abusers, it is not advisable to use the it is not advisable to do drug abuse, but even when somebody is sharing the needle, that is more and more dangerous. So we can avoid hepatitis B infection. We can take vaccination. Even if we get a needle prick injury, as a healthcare professional, we have to check our anti-HPS titer. If it is less than 10, we have to either take immune serum immediately or revaccinate. Both are very important. Thank you.